Welcome back, folks. We're going to go ahead and get started with our next presentation segment here this morning. Continuing with our theme on the yellow brick road of the treatment pathway. How do we get to Oz? How do we get to that magical land? Corey Bradley is the pharmacy operations manager here at CareOregon. Corey received his training at the Oregon State University College of Pharmacy. His professional interests include population management and also healthcare data analytics. Corey's worked on projects such as the Hepatitis C Patient Care Program, and he leads our Pharmacy and Therapeutics Committee as Agenda Coordinator. Corey also claims to be one of the only avid sports fans in the CareOregon Pharmacy Department. So you might often see his love for data analytics and baseball stats start to collide. I don't know if that's going to happen here today or not. We'll find out. All I know is when it comes to medication management, Corey hits a home run every time. Let's give a warm welcome to Corey Bradley.
All right, thank you, Paul. Good morning, everybody. My name is Corey Bradley. I'm a pharmacist with CareOregon. I'm the Pharmacy Operations Manager, and I'm also the chair of our Pharmacy and Therapeutics Committee. If you don't know what that committee is or does, don't worry, we'll get into that a little bit and talk a little bit about how that committee helps CareOregon. The title of my presentation is The Yellow Brick Road of the Treatment Pathway. Don't worry, I'm not the CareOregon guy. I'm sure everyone's groaning. Here comes CareOregon to beat us over the head with the pathway. Not really my intention. Really, we're kind of taking you inside the development of that treatment pathway. What goes into that? What factors do we consider? And how does it get made? So let's get into it here. Of course, our official learning objective and outline slide, like all good presentations have. Really, the main goal here is to help you guys feel effective in how to use the pharmacy benefit and really get the most out of it with the least frustration. To do so, we're going to cover about 5 different areas, starting kind of going behind the scenes, like I mentioned, Formulary 101, rebates and medication tiers, understanding changing costs of diabetes medications, some common pain points, and really get some best practice tips to help you be successful kind of in the PA world. But really, if I can be a little honest or transparent with everybody, where this conversation came from, I originally wasn't planning on presenting to Meds Ed. This was already in the works and gearing up with the clinical presentation and information that's already been shared with you guys. And in that run-up and having some conversations with the individuals, kind of bringing it together, I wanted to recognize there's some frustrations out there, some pain points, especially when it comes to insurances, PA processes, and formularies. But what I found is the people in the clinics that know us the best and understand who we are and kind of what we do, I think have an appreciation for that work. And I think it creates a better overall experience and really gives a better environment for us to kind of each meet our respective goals, which are really the same, to try to serve our members and your guys' patients. And so really what dawned on me is I think a lot of the frustration comes from when people don't understand or maybe only have part of the picture. So my goal really was to come in and give a transparent talk and show people and maybe have conversations that don't typically happen, and hope by sharing that information, we kind of, again, build some collaboration and trust with one another. So let's get into it. Let's talk managed care and CareOregon. First off, with the formulary process and how it all works. So first thing I want everybody to know kind of about CareOregon, all of our internal reviewers and all the recommendations regarding our formulary makeup, PA criteria, all of them are CareOregon employed pharmacists. They're all people that live locally and almost exclusively kind of in the metro area, though we do have some people living both on the coast and kind of in the Medford area. It's the same people that shop at the grocery stores or go to movie theaters. Well, I mean, they used to go to movie theaters when COVID allowed us to. I think they're open now, but you may want to hurry. I'm not sure how much longer they will be open. Our kids go to school. Well, again, we try to send them to school, and hopefully that too will be open come this fall. But my point is to communicate we're not some big national plan that's dropped into the state or trying to really squeeze profit out of Medicaid and make bucks for stakeholders. We really are a group of pharmacists and non-pharmacists that support our whole team to help serve our community and ultimately try to do the most good we can for Oregon Medicaid. The committee I mentioned earlier, our P&T committee, it's made up of both doctors and pharmacists. It's both internal and external. And by policy, we have a policy that has an external majority. So that means all of our recommendations for formularies, all of the PA criteria are being voted on essentially by your peers and ultimately with more votes. So if there is a problem with kind of how the criteria are being developed and managed, we have that external input and advocacy to make sure our members are being treated in the best care possible. We do have representation on that committee from all 3 CCO geographic areas we serve. Just kind of some examples, we have representation from Virginia Garcia, Multnomah County Clinic, OHSU Richmond, some of the Providence locations around the state, and more. So whose formulary are we responsible for? Anybody that's worked in the Medicaid space long enough in Oregon knows this is actually very complicated. Some might argue way too complicated. So of course there is the OHA fee-for-service, or AKA open card. Definitely not. I'm not responsible for that. All the things I'm about to say today don't really apply directly to OHA. The 2 I can say yes for sure, Columbia Pacific and Jackson Care Connect. Health Share of Oregon, well, it's a little bit complicated. So there are different entities within HSO. I do believe CareOregon is the largest one of those entities, but you kind of have to know which entity to know which formulary or PA criteria you're really talking about. So why aren't formularies aligned? This is a common question, common point of frustration or suggestion. If formularies were all just the same, imagine how much easier it would be on prescribers. And there might be some truth to that, but I'm here to maybe dispel a little bit of that myth, but also emphasize why they're not the same, why they're not aligned. And the first point is they're actually fairly well aligned, over 90% when we've done some analysis of comparing other local plans, greater than 90% are aligned in the standard medications covered. Where the differences mostly show up tend to be in brand names. And that's why we kind of mention it here. I'm taking a little bit of a tangent outside of diabetes, but I think when we get done, you'll kind of understand why. Diabetes certainly is one of the areas where you have different drug classes, different brand competitors within those drug classes. And so as those prices, and in particular rebates, might change from plan to plan, don't worry, we'll talk about rebates here in just a second. That's how you end up with kind of this lack of alignment with different formularies. Other factors that go in, autonomy, political pressures, or being part of a larger system or company. So like I said, CareOregon, all local pharmacists working to make these formularies and go through our local P&T committee. The other great part about our system is it's that same group doing the PAs. So reviewing and seeing those rationales come in from providers, seeing those drug costs when we're doing a PA. It creates essentially a closed loop system where we're able to identify weaknesses in our formulary or our criteria and try to adapt to it. In fact, for this, coming out of this talk alone, we've already processed a couple of changes to try to make our criteria better and work in a more simplistic fashion for our providers. We got those through our July P&T committee meeting, and they're live as of August 1st. So essentially, within a couple of months time period, we were able to identify some changes we needed and make those changes. And we'll highlight some of those coming up. So what's the deal with rebates? Imagine most of you guys out there have heard of rebates or familiar. Maybe you even have a pretty good understanding already. But it's really a key concept that drives a lot of this. So at its base, rebates are just a discount. It's offered by the manufacturer, typically negotiated with PBMs, the pharmacy benefit managers, or the health plans themselves. Essentially, they say, we'll give you a discount behind the scenes if you make our drug preferred, or you make our drug without PA criteria. And so it's a way that the manufacturers are able to kind of jockey to make their product used more often. What's important for people to know is that there's varying levels in which rebates are available based on whether you're talking a CCO or a large commercial formulary or even Medicare. So historically, there's fairly minimal supplemental rebates for CCOs, or at least at CareOregon, whose perspective I kind of represent today. So typically, when we're making the Medicaid formulary, rebates actually don't have a large impact in kind of how we make those decisions. But for other commercial players or in other Medicare, it can be kind of a large factor. Even for our own Medicare, rebates do play a larger role kind of in how decisions get made. Rebates have fallen under some recent controversy. There's information in the news and legislation that's trying to move rebates to make sure that it benefits the patients as well. Luckily, within CareOregon, since we have essentially no copays in our Medicaid space or really limited copays in our Medicare space, there isn't much of an opportunity for things to go poorly for our members. However, in some other settings, you could have scenarios where, say, a commercial insurer offers a preferred agent, and that agent could be more costly, but they do that because they get a large rebate behind the scenes. Now, that commercial insurer might argue that rebate helps them keep costs down across the board, keeps premiums low. But there's also an argument that they're making then that benefit perhaps at the expense of the member. So there are efforts to try to make sure that patients are part of that benefit so that they are directly seeing their own copays come down when they're a part of a rebate. Moving on to another hopeful myth. Why does CareOregon PA so much? And I should have asked you guys before we jumped into this, how much of the drugs, how many of the claims do we require PA? I'm betting some of you would guess, oh, CareOregon has to PA at least 50% of the drugs. All they do is PA things. Every turn I try to make, it needs a new PA. And I get it. But actually, when we look at our claims, more than 99% don't require prior authorization. But I know how frustrating and kind of burnout the prior authorization process can be. So it certainly makes sense. Even if it's a very small volume overall, it certainly still is really impactful to providers as well as the health plan. So if we know that there's some negatives to it, why do we do it? Well, really it's in Medicaid, our only cost containment tool. As I mentioned, there's minimal rebates. So we're not really having substantial lowering of drug costs behind the scenes with negotiating with those manufacturers. And I've already mentioned for Medicaid, we don't have any copays at all. So another commercial insurance and even some Medicare plans, again, can rely on tiering. So that is where they kind of say, a tier one's preferred. Maybe those have no copay at all. Or maybe, then there's a tier two, a preferred generic, a little bit of a copay. You pay $5. Tier three, maybe it's a brand and you need to pay $20. And then you get to a tier 4 or 5, and maybe it's specialty. Could be talking 50% coinsurance. When you have those copays and tiering available, those other insurances could get away with not relying on PA so much because they're basically and quite literally passing the buck on to the patient. So if a patient has to pay $200 a month, maybe for a GLP-1, maybe they don't need to PA a GLP-1 because the patient is going to have essentially some say in whether that is valuable to them. And it's always important and hopefully can keep bringing people back to this kind of central point at CareOregon. It's why I love working here. It's why I feel good about the work we do and I've done over the last 10 years. CareOregon is nonprofit. So that means all the money we are trying to save through the PA process is going back directly into serving our membership. Sometimes that's holding on for stormy times ahead where expenses go very high. Sometimes it's expanding to new services. And on a big picture, back to the state level, it might allow for more Oregonians to be covered under Medicaid. Kind of the age-old adage, money doesn't grow on trees. And I think we all have to realize there's a fixed amount of money out there to serve Medicaid. If everybody got every drug they wanted, regardless of cost, there's less money to go around. And the only way to react to that is to serve less Oregonians. And so really our approach in a PA in the end is trying to make sure that we're using Medicaid dollars in the most effective way possible to serve as many Oregonians as we can. Okay, get ready. If you have a notepad or in particular, if you can use the chat, Microsoft Teams, I'd like to hear from some people, see what you think. We're going to get into drug costs. And so I'm curious to know what everybody thinks of drug costs. So first thing I'd like you to do is I'd like you to identify the drug class or the type of medication. If you're not familiar with the classes, that's okay. Write down a drug name, maybe, that you think is the most expensive to treat diabetes. And I'm not talking specialty, crazy repercussions of diabetes. I'm talking run-of-the-mill, standard guideline therapies for treating diabetes. Which class do you think costs the most? And then I'd like you to think a little bit more about that. How much a month do you think that medication class costs? Is it $50 a month, $100, $1,000, $10,000. What do you guys think? So I'll give you a second. I'll grab some water. You guys throw some in the chat. All right. Let's jump in and see. So I've gathered the kind of the main classes here, with metformin probably being the cheapest one out there. Though, if I really wanted to be technical, I could almost make a case metformin is the correct answer. There are some ER 1,000 milligram formulations out there that cost thousands of dollars. And so if anybody's ever been out there and you see CareOregon and, oh, they rejected metformin, and you're thinking, oh my goodness, again, CareOregon, now you're PAing metformin? Well, most of the time, we know what we're doing. We're paying attention to drug costs. If we don't cover something or a specific formulation, 99 times out of 100, it's for a pretty good reason. And so in this case, again, there are literally some generic metformin ER products that could cost thousands per month. That actually wasn't the answer I was looking for, but I kind of wanted to make a little bit of a fun point, or a fun fact, if you will. So GLP-1s at the bottom of this slide here, depending on what time of the year really you're looking at. I've been watching a lot of Olympics, and you see people running around the track, and they start kind of in a staggered line if they're running, a longer distance. It's kind of where the GLP-1s are. Where are you on the track of your yearly price increase? And that's going to dictate whether you're in the $800 or the $1,000 range. So you might be in the $800 range now. Next month, you might be in the $1,000 range. SGLT2s are kind of underneath that, $300 to $525. Steglatro, as has been mentioned, our preferred SGLT2, is on that lower end, that $300 range. So why might Steglatro be cheaper? Why would it be $200 less than some of these other agents? Similar to the GLP-1s, but on a percentage basis, that's a much bigger cut. My hypothesis is it comes down to, when did these products hit the market? Because they're all out there and they're all trying to negotiate rebates and make plans with health companies. And so health plans, if they've already locked in agreements for Jardiance and Invokana, chances are they're not going to offer a great rebate structure with a Steglatro. So Steglatro kind of comes out and is either a low rebate or free rebate option. So basically they're offering a lower price without a rebate. And as mentioned before, sometimes it's really helpful to health plans that don't have access to a lot of the rebates, like CareOregon. Let's continue on. So you may be wondering, well, you didn't mention insulin. What about insulin? Maybe you wrote down insulin and thought that was the most expensive. Well, in the last couple of years, in particular, probably before COVID really took over, insulin prices was really in the news. It seemed like every night you could turn on, you'd see that story. Perhaps some of you have had the unfortunate scenario of having a patient that's having to ration their insulin, or maybe their grandmother. They're supposed to be on 20 units and they're only able to use 10 because they need to stretch it a little bit further. They can't afford to take it as it's being prescribed. And it's absolutely true. You're right, Ron Burgundy. It is kind of a big deal. Absolutely. And insulin prices are or were out of control. That's actually changing. And one thing, and we'll show how it's changed here in the next slide. I also want to call out a little bit of a canary in the coal mine. So while a lot of fixation was on insulin and the mind-boggling percent increases that you've seen over the last couple of decades, really they were not alone. Every other drug therapy is out there increasing their prices. So I kind of like to joke a little bit. There's been a little bit more pressure for drug companies to not increase their prices in the same way that they have. I'd argue the current strategy is kind of borrowed from gas stations. The pharma industry promised they would not increase pricing by double digits. So you literally see some brands out there now with a 9.99%. So they did not cross the threshold for 10%. Some of them still do cross the 10%, and no, they don't go to jail or anything bad happens. To be fair, some of the biggest pharma industry makers have done a lower percent increase, maybe a 5% year over year. But none of them have gone back on the 20% year over year increases that they did for decades. So maybe they've slowed down now, but that's built on some momentum or even their starting positions that are often ridiculous. So I'm not exactly ready to hand them my Olympic gold, silver, or even bronze medal. Before I move to the next slide, I'd like to talk about insulin prices. I foreshadowed a little bit here, but I like break out the chat again. What is the least expensive insulin that you can think of or that you think's out there? So the least expensive one, and then throw in a dollar figure with it. How much do you think it is per month for that insulin? So we'll give everyone another second here. Okay. This table is looking at insulin pens. So 15 milliliters. You've got your 5 pens. I think there's 3 mLs in each. And I've got what I call the OG brands, the names everybody knows and loves over the last couple of decades. Lantus for your most famous, I would argue, basal insulin, Novolog and Humalog, and of course some of the mixed insulins as well. What's interesting is happening in the insulin space. It kind of connects to the FDA recently making them classified as a biologic. So you might think of things like Humira or Stelara, Remicade as biologics. They actually consider insulin biologics now. That has to do with kind of the complexity of manufacturing, and it wasn't a good fit for the standard brand generic pathway in terms of making a truly identical copy. Now, don't get me wrong. What's happening is making the same insulin, and it's in the same amounts and works exactly the same way. It's just at a technical legal level, it really wasn't a good framework for finding authorized generics. So now what you have are competitor products. So basically, they are alternative brands that market themselves at a lower cost. So the answer to my question, maybe a lot of you wrote down NPH. Actually, that is no longer the correct answer, at least when I look at kind of an average wholesale price-based scheme. Semglee, which is an insulin glargine, so essentially the same as Lantus, now at $450, a third of the cost of Lantus, and that's even a little bit less than NPH. In the mealtime, you have Admelog as the competitor. That's the cheapest one that I'm aware of at $255 for that 15 ml pack. And then some of you may be wondering, wait a second, I've seen generic insulins out there. This guy clearly doesn't know what he's talking about. Well, you're both right and wrong. There are generics out there, but they're called authorized generics. That's basically when the brand company decides that they're going to allow someone to kind of step on their patent, make the same product that they're currently making. And that manufacturer that they are allowing is actually themselves. So they are basically making a bunch of Novolog, making a bunch of Humalog, and then some of them they slap on the name brand label, some of them they slap on a generic name. So it truly is the same insulin being made by the same people. The difference is there's no rebate on those authorized generics. So they actually then offer it at a 50% discount. But no, again, if you're wondering, well, good for them. Well, really the only reason they did that is because things like Admelog came out. I also would argue some of that pressure and blowback and insulin being in the news all the time probably had something to do with helping to push the release of these authorized generics. All right. I wanted to address cost trends. We mentioned it before in insulin in particular. I've shifted gears. We've moved to the vials, 10 ml vials for Humalog and Lantus, showing when it was first approved, at least when I could track it back and find a price. Incredible pricing, $50, $60 for a 10 ml vial. Over the last nearly 20 years, you can see that those have gone up 4 or 5-fold, 462, 461% by my count. Just incredible price increases. Farxiga, you might notice, came out just a few years ago, but has already seen a 71% increase. So essentially averaging around a 10% year over year. And then Victoza, look at Victoza in 2010 came out, was less than $400. And as I mentioned, now we're up to over $1,000. So a tripling of the cost of Victoza. So certainly insulin not alone in showing their steep increases in prices. I have another fun fact for everyone, or maybe just fun facts for nerds like me. If anyone was really out there and you've got a calculator and you're like, wait a second, these costs don't add up. That 15 ml and this 10 ml look a little funny, look a little different. Well, it's because the vials in mealtime actually cost a different amount per unit for Humalog, the mealtime. So for Lantus, for example, costs the same amount per ml per unit, whether it's a vial or a pen device. Humalog and Novolog actually cost a little bit more. I don't have the exact percentage on me. I think it's around 15% more. So that premium they charge. You may be wondering, why would they charge more for a pen device for mealtime than they would on basal insulin? One of my mantras or principles believed by all pricing has a reason. And I think my theory is simply that it comes down to people are willing to pay for it for mealtime. If you're having to use that 3 times a day, that pen injection is worth just a little bit more to you. So the industry can squeeze just a tiny bit harder. All right. So I've given a lot of background, costs, hopefully starting to shed light on some of the factors that go into it. Now, I know everyone's thinking, well, you can't make it only about costs, and you're absolutely right. But hopefully you're starting to understand why this is difficult, and we'll continue to build on that. Dr. Berteau already covered the diabetes treatment pathway earlier, so I'm not going to hammer this home in a lot of detail. But there are a couple of things I'd like to point out, and certainly repetition never hurts to help build on some learning. So as mentioned, our first and second line, really looking for some oral failures of those lower cost agents, but still reasonable and good agents to use. The third line then is when kind of moving to the SGLT2s or DPP4s. This is actually a little bit earlier. In not so many years ago, I believe CareOregon, we had 3 different oral failures. So instead of an or up on that second line, sulfonylurea or pioglitazone, might have been all 3. So we have tried to listen and kind of, again, it's all a balancing act, and have introduced the SGLT2s into that kind of third line along with alogliptin. Fourth line then is insulin, but it's important to kind of note, it's here fourth line just visually for a couple of reasons. One, fits best with kind of how the GLP-1 criteria are structured. We are looking for insulin to be used, at least basal insulin, in most instances, before going to the GLP-1. So it makes a nice visual to be consistent with GLP-1. Also, just kind of an experience, most providers probably trying to look to exhaust oral therapies, trying 2, 3 before moving to insulin. But truly the basal insulin and the mealtime insulin, so our products, basal again, our preferred agents, Basaglar or Semglee. NPH is also covered, though not prescribed too often anymore. And then Admelog is our preferred mealtime insulin. All of those are available without PA. So if a provider wanted to add it earlier in the line of therapy, there's nothing that prohibits that from a formulary standpoint. All right, so what hasn't changed? Well, really the general stepwise approach has remained fairly consistent kind of over the years. As I mentioned, we helped move up some of the SGLT2s and DPP4s a little bit earlier from a couple of years ago, but really the sequence of therapies and kind of the preferred agents, kind of staying the same for most patients. So what has changed? Again, I know this has kind of been addressed before, but just to kind of highlight a little bit, before the visual on the pathway had more A1C references that perhaps were a little bit confusing or could conflict with the PA criteria. But I really want to emphasize a broader range. This was one of those recent changes we made at our July P&T committee that we mentioned earlier. So now, if you saw on that previous slide, we double back real quick, 2 previous slides, I guess, you can see the PA criteria boxes there with the A1C of 7 to 10%. That's the same window in that third line box as well as the fifth line. So moving back over here, that used to be a 7.5% minimum. The mentality behind that was, well, if you're at 7.5 and if a goal was less than 7, do we need to add really expensive therapy to boost just a little bit further on A1C? But I think what ultimately we found was, well, but you're also asking them to introduce this after several failures. So trying to squeeze just a little bit more on diet and exercise modifications, maybe just not very reasonable. So have dropped that down to 7. Similarly, the 9 to 10% is kind of on the same concept. At some point, if the diabetes is not well managed and it's a very high A1C, it could start to make a stronger case for insulin. But with a 9% cap, it was perhaps just a little too aggressive. So we've broadened that range, and that just gives really a lot more flexibility. My hope is it allows providers to focus more on the sequence of therapies and talking about why one drug's appropriate versus another, rather than introducing kind of too much complexity in the A1C. Greater than 10%, it's not a hard cap, it's just bringing in now more conversation, looking for more documentation that insulin's been considered. Continuing on, some of the key changes here that already been mentioned, some of the Farxiga specific allowances. So again, I think this is a reflection of where we're trying to stay evidence-based. Farxiga has added more indications in unique populations that Steglatro still hasn't added. So we are recognizing that, and, for example, established ASCVD, CKD, and heart failure, kind of being the three main ones where us pushing Steglatro over Farxiga wouldn't necessarily back up in evidence, and thus kind of why that allowance is made. The last one I really want to talk about, which is removing mealtime and the GLP-1 restriction. This was another change that came out of this process. One of our early conversations with Dr. Berteau was understanding what did he like kind of about our pathway, or what did he really not like? And he did have some things he really didn't like. And this was probably the biggest one. I think you would agree. And said, really this complex patients and doesn't necessarily make sense. And so we went back, looked, and decided ultimately, let's remove this, because agree, these are complex patients. And seemed to be in a couple of examples we had only getting in the way or making it a little bit more difficult to manage. So again, trying to make some positive changes to make it a little bit easier to work through the pathway. Continuous glucose monitoring. Originally, this wasn't going to be in my slides. And the main reason being at CareOregon, it's not a pharmacy benefit. So I'm not exactly the expert here, but we've gotten a lot of questions about it. Dr. Berteau, I know, mentioned earlier this morning that I was hoping CareOregon might kind of address it. So I had an inkling that would be the case. So I've added in a slide here to address kind of the standard criteria for continuous glucose monitoring. As I mentioned, it's not a pharmacy benefit. It's a medical or DME benefit. So Medicare can allow claims to process via a pharmacy, though it's still doing that as an actual Part B claim, which is kind of the classic medical benefit. Authorization is required for both Medicaid and Medicare, though the criteria I've learned is actually quite a bit different. The Medicaid criteria, and also maybe important to note, CareOregon actually doesn't really set the criteria that I've listed here. Both are actually coming kind of from the top down, if you will. So Medicaid, this is coming from the HERC. If you're not familiar, the HERC is kind of I believe it's Health Effectiveness Review Committee. And they are, I may have made up that acronym, but summarizes what they do. They help set kind of the benefits for organ Medicaid. And so they've outlined kind of this criterion, reviewing evidence and similarly looking for value. So they've said only for type 1 diabetics, needing to show that documentation or education has been provided to the member so they know how to use the CGM. And then they have to fall into one of these end buckets on an insulin pump, an elevated A1C of 8% or higher, frequent hypoglycemia problems. And then they have a couple of other specific populations, including pregnant women and very young adults or children, so ages less than 21. I understand for pregnant women, CareOregon, that's one area that the type 1 diabetes is not being enforced. So type 2 diabetics for pregnant women on insulin would be given an exception. All of these require renewal after a period of time to show that the members are, in fact, actually using the CGM. Medicare is a little bit different. Standardly does allow for 1 or 2 diabetes, but looking for kind of that intensive insulin regimen. So 3 injections per day or on a pump and requiring frequent adjustments. So both of them really kind of getting to high-risk insulin use, really needing this close monitoring to help them be successful and safe with their therapy. All right, a couple more sections on my talk here. The next section might get into what is some of the more controversial. And I'm kind of leaning into that a little bit and kind of inviting everyone to step in and really think critically about this. If I'm being totally honest, value and cost effectiveness is not a strong part of what healthcare is built to do in the United States. It's also why our drugs cost the most. A priority is put on ensuring or encouraging innovation and new drugs, but that comes with very, very strong patent protections that allows them to essentially charge whatever it is that they want or think that the market will bear. Other companies don't give them that level of patent protection, and that's why you have cheaper drugs in other countries. Oversimplifying, sure, but that's basically getting to the bottom line. So let's get into a little bit of how we should factor in cost, or at least how we do in CareOregon, and invite kind of you guys to think critically as well. So guidelines versus practical reality. Surely we hear some complaints that guidelines say I can use a GLP-1 whenever I want. And that's true. There are broad guidelines and they give a lot of different options. Though I would note one of the key guidelines has a when cost is a factor. That's definitely our section over there on that side. Cost is definitely a factor for us. And so that's really what we're trying to kind of make sure we work within the most cost-effective options. And so these tensions come up where health plans, we're trying to get value. We're trying to make sure costs stay as low as possible, but the guidelines typically never do. And to be perfectly honest, sometimes guidelines go the other direction. They're actually heavily funded by the industry. So that's how those guidelines get published. So it is a catch-22. You need funding to put together these publications and fancy graphics and all of that. So some of it's necessary, but certainly it's hard then. How does it not introduce a conflict of interest into those publications? And so I think some people don't always recognize that guidelines, as much as we respect them, aren't immune to bias. They're not immune to pharma funding and some possible, again, just bias. Also, obviously, funding out there and drug reps. We may have some in the audience. I mean, no direct disrespect to any of you, but certainly that plays a factor in the tensions as well. If you have someone in your ear telling you every day that these new drugs are the latest and greatest and are absolutely necessary, if you don't have another source of information or a counterpoint, that's hard to reconcile. Actually, kudos to all of you guys for attending today and listening to this talk. And hopefully you're still here at this point in my presentation and hearing me out, because it means you're open to kind of hearing and understanding, thinking about it from a different perspective, a different lens. So I appreciate that, and hopefully that's helpful for you guys. We like to joke, there's no pioglitazone drug reps out there. No one's really out there talking about, yeah, it's an older drug. Yeah, maybe its cousin had a bunch of really bad problems, but actually at the end of the day, for most patients, it can actually be a very good drug. The last point is being really critical of the trials. So when a drug trial comes out, there are very specific parameters in place of who they studied and when, what other drugs were they allowed to take or not take. And at CareOregon and most managed care entities, they're probably digging into that a lot. Just because you have evidence in reduced ASCVD doesn't mean that all patients are going to have reduced ASCVD. So it's important to look at those details and understand what was that population looking like? Because we want to make sure if we're paying for an expensive therapy, that it's in the population that's been proven to get that extra value from. So that just another piece of what we do that could kind of generate tension. All right, I'd like to give a little bit of an example here for everybody. So we're going to go through an exercise of assessing value and the cost to avoid one event. This is one way to help try in some way to put in perspective the value of a drug. This is probably my most controversial topic or subject, but I'd like everybody to think for a second. If a drug was guaranteed to avoid a heart attack in someone, but it cost $1 billion, should, as a society, we pay for that $1 billion drug? And if the answer is yes, every patient's worth it. Well, what if it's $10 billion? I'm like, well, still yes. What if it is a Jeff Bezos flies to space $1 billion? Is that still worth it? And I'm hoping by now, most of you agree there's some threshold that we just can't as a society. It's too expensive. We can't do it. So if you agree that there's an endpoint, then you at least agree that there's some scale, there's some point. And there's academia out there and things of cost per quality, a quality adjusted life year, some really objective terms to kind of frame what dollar is worth what event. But really, if you just think about it in more simplistic terms, there's the Jeff Bezos going to space cost of a drug, and then there's the metformin cost of the drug on the other end. Those low cost but such high quality outcomes, you're literally going to save money. Them taking metformin is going to keep them out of a whole host of complications. In between those 2 points is a line. In the middle section, that's where it gets gray. And that's where it gets tricky. What's a value? What's worth it? What's not worth it? So let's just play through an example. And I'm not going to say whether this is worth it or not, but you think about it. Where does it fall in your line? So Victoza, I went in, pulled the FDA label. I'm looking off the results from the LEADER trial. And it indicates that Victoza, I could come up with a talking point. It doesn't literally say this, but I could come up with a talking point. Maybe a drug rep has shared this talking point. a 13% lower rate for total cardiac events. Well, when you go dig into the details, and we're just going to kind of chip away at this argument, we're going to think critically about this. That's about 1.2% absolute lower rate. How do you think about that in terms of patients? A common term we like to use is the number needed to treat, NNT. So it says, how many patients do you have to give that drug to avoid that one event? In this case, it's 53 patients. Okay, that doesn't sound too bad. Let's keep kind of chipping away here. How long were those patients studied? In this case, I found it was a median duration of 3.5 years. So now we're going to treat 53 patients for 3.5 years, and we're going to do that with $1,000 a month Victoza, so $12,000 a year. That comes out over $2.2 million of drug costs to avoid that one cardiac event. While it is true that that is more, I think, than Amazon paid in income taxes or revenue taxes, it's still a lot of money, and I think gives some serious consideration. How much should you pay for a drug to avoid a cardiac event? So again, I don't have that answer. I don't know if it's 500,000, a million. Is it 3 million? Maybe it is worth it, but certainly starts to paint the picture at a population level, how difficult it can be to weigh what evidence, what costs are all kind of worth it. So really the pathway ultimately is our attempt. We're trying to balance this approach, trying to ride that line of cost-effective care, but still making sure that our members have access to appropriate care that's going to ultimately improve their health. Let's frame this another way, and I have more million-dollar figures up here, but I am out of Amazon and Jeff Bezos jokes, but important nonetheless. So let's frame it in a different way. Probably the most specific feedback or concern, frustration that I hear from providers is, I want an SGLT2 second line, right after metformin. Why not? Well, let's take a look. What would happen if we made SGLT2s and the different options, or GLP-1s, what if they were second line in the pathway? So maybe one way to proxy this is let's look at all the people that are on a second line agent. The biggest one we have is sulfonylureas. We have about 2,000 members currently on it. So let's go ahead and say, in a hypothetical, they all shift over to one of these second line agents. So we say, all right, those 2,000 members, they're filling 4,000 prescriptions a quarter. Let's multiply it by the cost difference in these two different prescriptions, 4 quarters in a year, how much money? And so you go ahead and see over there how much millions of dollars we're kind of adding, going all the way up to over $14 million for Trulicity. For perspective, our total diabetes spend with our current criteria that some people might argue is overly restrictive, and we know there's some frustrations with it, it's already $19 million that we spend on diabetes. So, potentially talking a near doubling of our diabetic spend if GLP-1s, were sitting second line. So again, some of you may out there feel that this is worth it, but hopefully you're getting the point or understanding this is the ultimate tension that we're trying to wrestle with. How many more millions of dollars can you spend? And ultimately, is the health of the members going to be better and better in an amount that warrants that amount of money? All right, so let's get back to being a little bit more practical. I promise to end with ways to help you be successful in using the pathway. Hopefully we've got you all thinking critically, maybe thinking more like a health plan, at least understanding our perspective, even if you don't ultimately agree with it. Hopefully it gives you some things to think about. Common pain points that I see. Well, so the high A1Cs and not having that insulin discussion, that's one that trips up a lot of PAs, maybe ends up second PA's appeal. So if it's greater than 10%, again, that's not a firm cap. But it is asking for an evaluation, a documentation that you have that conversation with the member. So one example that I've seen before, though there's lots of reasons and examples that insulin may not be appropriate. Maybe they have a family member, a sister that had a really negative event. Maybe they even associate a death with a hypoglycemic event, and they refuse to take insulin. Of course, if we're at a point that members refuse insulin, that's a pretty good reason to, not use insulin because they're just not going to use it. We understand that, we get that, but that's the type of discussion and documentation that we're looking for when those A1Cs are really high. Again, that comes from our perspective that with that high of an A1C, it could be their best chance at control, at least from kind of an absolute A1C evidence reduction perspective. Another point on the A1Cs, all of the meds that we require PA on diabetes for it uses A1C in some way, shape, or form. So please send us that A1C, avoid kind of a frustrating denial. Also, it's probably important that be a recent A1C. If you send me an A1C from 18 months ago, probably not very helpful, since we know you probably need to be getting those every 3-6 months, or at least that's kind of the typical window. We're looking, say we approve a drug, we're looking in 6 months. Has their A1C had a significant improvement? Next up, failed or not failed. At the very beginning, I mentioned our team. It's a bunch of pharmacists and clinical pharmacists. So they're reviewing all of these cases, go through them. So if we're just seeing a box check like, yeah, Stiglatro, we tried it for a week, failed. But if it was only a 1-week trial, could it have actually been failed? How could you possibly assess effectiveness at that point? So just because something's stated as failed doesn't mean our team will accept that failure. So understanding a bit of details, how long they used it for, what happened to their A1C, or do they have significant side effects? Those kind of details can go a long way in helping to move your request forward. One point that we have an opportunity to communicate on, and I actually have a kind of an interesting story. This just happened, and not for diabetes, but I think it exemplifies kind of the adherence point here. It's often we see things as failed, and then we go look and see, well, it was failed because they never actually filled it, or they never picked it up from the pharmacy. On the provider side of things, you may not know that. They may fail to mention it. They may even tell you that they took it because they're embarrassed that they didn't. So we see a lot of that. That's everywhere, of course. So my recent case was a PSCK9. I think I got that acronym correct. All the letters for sure. For those not familiar, those are super LDL lowering drugs, kind of this new class of medication that came out years ago and has drastic LDL reduction. And so, of course, it's fairly expensive, and we have criteria. Top of the list is failing a statin. We get a request and it says they failed the statin, their LDL is still 160. Our pharmacist takes a look at their claims records and see they haven't filled that statin since, I think, January. And this is a person who has had, I believe, 16 or 17 different cardiac interventions, a heart attack at the age of 30, and now they're 40, and they're not on a statin, and their provider thinks that they are. Obviously, that's really dangerous and important information that we were able to relay back to the provider. Their LDL is so high because they're not actually taking their statin. So that's something we're working on. How can we make sure we're communicating back to providers, things that we see, information maybe we have that is not known to the provider? So we've recently added a note section that can go specifically to the provider and not the member. All of our communications are really geared towards a member, and that's by Oregon Medicaid law, essentially. And we have to word things at a 6th grade reading level or lower. That can be a challenge then when we're trying to communicate to a provider. So recently we've added that new note section for providers only, allows us to be a little bit more specific as to what's going on and what we want you to know. Other things might be kind of scrutinized as well. If somebody failed metformin and the notes say they started at 1,000 milligrams BID on the immediate release and they had diarrhea on the first day, well, then maybe there's other options to try to tolerate that metformin a little bit better, maybe starting with a lower dose, using an extended release option. So our team may not be quick to move on and say, metformin's been failed if they think there's a clinically reasonable other way to kind of go about it. Moving down on kind of the common pain points, the term contraindicated, and in the mighty words of Thor, yeah, is it though? We see this thrown out quite a lot. Contraindicated is kind of synonymous with, I just don't want to use it, so please stop bothering me. Sometimes it really is contraindicated. So the key is knowing specifically what the risk is in mind. Contraindicated is not I think GLP-1s are better. Maybe you do, but that doesn't make it contraindicated. So being really clear on what the patient-specific risks are, right, is definitely really important. And then being familiar with the preferred agents, SGLT2s in particular. It's nothing more frustrating perhaps to providers or to us. You get through the pathway, you've used it, they qualify for an SGLT2, and the wrong one was asked for. And now we have to deny a Jardiance and say, you need to please go and use Stiglatro. Maybe a new PA is needed, and it's even more administrative burden. So leading into it just a little bit, being familiar with what the criteria are, the preferred options, could save you a lot of headache kind of in the long run. That segues into my PA best practices. What are some suggestions I would give to everyone to help not make those mistakes or help get through those barriers? First and foremost, criteria, it's fully posted online. It's on the CareOregon website. It's on all of our CCO websites. I'm pretty sure it's a Medicaid statewide requirement. So if you serve in an area with other CCOs, their criteria should also be fully published online. We are moving towards EPA in the year 2022, still working out the details of how that looks and how it works, but provides an opportunity for us to ask more specific questions of providers, improve that communication, hopefully get more to what we need in an easier way to submit process. Similarly, the formulary is fully posted online, so you can find that as well. Probably the two best practice points I can make to you. If you leave with nothing else, this bullet number 3, stick to the pathway when you can. And when you can't, just please explain why you're not following the pathway. And please make it a patient-specific arguments. We also know that pharma puts those pre-canned letters on their website, or perhaps go around handing out, here's what you need to say to get your continuous glucose monitoring approved. We know that that's out there. And again, with our team reviewing all of these, although maybe not the CGM, but if we see that form letter, that's probably going to be a quick to dismiss into the denial pile of the authorizations. Getting authentic and genuine rationales from the providers, while we may not always agree, is almost always going to be a better way to have an apples to apples conversation about what's best for the patient and has the best likelihood of getting approved. So I can't stress that enough. Genuine arguments. When we see shifting arguments, we see it was failed, it didn't work. And then an appeal like, well, they had a side effect, or, they can't use it. When things start to feel lacking kind of authenticity, certainly makes it harder through the PA process. Last point, I've mentioned this before, but can't emphasize it enough. A1Cs, documentation in general. Documentation is always going to help you. Send your most recent chart note. That'd be my best recommendation on everything. Ideally, you'd find the perfect chart note that talks about past drug failures. I know that can be time intensive and hard. If you just grab the most recent visit, I'd bet 4 times out of 5, that alone is going to be perfect in what health plans need. Says the guy who's never pulled chart notes and sent to a health plan. So take that with a grain of salt, I guess. All right, I'd like to pick back up on the case study. Dr. Berteau shared this earlier on. And some of you, if you guys have been kind of thinking and following along here, may have thought, well, wait a second. Dr. Berteau went to a GLP-1. Doesn't necessarily fit kind of with the pathway. So let's recap and go through some key questions here. It's a 32-year-old female, 425 pounds, and the A1C is 7.1%, and they're on oral metformin and oral pioglitazone. What would the pathway ask for next? So I'm going to pause there, open up your chat, send that in. So again, metformin, pioglitazone, A1C is 7.1%. Where's the pathway driving this to from a standard formulary and PA perspective? Waiting to see more show up. I know Paul's watching the chat. All right, so let's move forward. So the pathway, we would be in that 3rd tier line. And so we are looking DPP4. We are looking SGLT2, probably the most common one that I think would show up next. And even if we're going all the way to the GLP-1 and kind of the 5th line in this case, that also starts to introduce insulin, since we are going from kind of a 3rd line to 5th line. So it brings in that 4th line option. So Dr. Berteau has probably considered this and feels the GLP-1 is best. So if you were this provider and you want to send in a request for a GLP-1, what might you want to specifically consider and include in that request to increase the likelihood of it getting approved? So what arguments are you going to think about before sending in an exception? Which kind of reminds me maybe of a really key point that I failed to mention before. Maybe starting with the question of, do you need to ask for an exception? Maybe you get to this point and think, you know what? I do think Stiglatro would be fine and I'm going to change. So again, that might be one way that being familiar with the pathway, the criteria could help you. But let's get back and say, no, I really think a GLP-1 is important. Really the answer here, it can vary broadly. But the main thing is looking for arguments, documentation, resources, things that point to support why a GLP-1 is necessary and why a DPP-4 is an appropriate SGLT2 and insulin. And there could be lots of reasons, and maybe more to this case, but patient-specific arguments are going to be kind of the best chance of getting that exception approved. And so then to the final bullet, let's say we got that great argument from you, our team agreed and approves it. In 6 months, that GLP-1 requires reauthorization. So what information or documentation do you need to submit on that renewal? Hopefully this is fairly obvious. Hopefully you still got a little caffeine going in you. You can draw back to that earlier slide. What was the outcome the patient had? So again, in this case, that was a pretty good reduction in A1C, bringing them to goal, and also some substantial weight loss. A1C absolutely would be the right answer. I'd throw in the weight loss for kind of some bonus to help show the good response that this patient is getting. But the A1C, really the key point there to show that the patient is having success on the GLP-1. All right, so final slide. What can you do? And if we were to, I'm going to go back to an example. I mentioned the PCSK9s earlier in one of my PA examples. That example had reminded me as I was preparing for this talk, something really unique that happened. And I don't think it's gotten enough publication or consideration. When the PCSK9s came out, there's a lot of concerns. You know, how much evidence does this really have? Sure, it reduces LDL, but what else? It's also really expensive for just lowering LDLs, especially with statins being the mainstay of the market and, you know, very cheap at that point. Why should we pay $1,000 or I don't remember what its entry price was? Well, what happened is no one prescribed it. Our team was ready, went through P&T. We had robust criteria with LDL thresholds, statin requirements, statin re-challenge, which is a real thing. You can have some great success re-challenging statins if you kind of know what you're doing. There's some great literature out there on how to do that. So we're ready, and we barely got any requests. Just prescribers were put off by the price. Patients were put off by the price. So what happened? They actually reduced the price, which is almost unheard of, short of competition like insulin we mentioned before. So they actually cut the price because no one was prescribing it. And I point this out because this shows that there is power that we have as a society, as healthcare providers. We have to put some pressure on drug pricing. We can't just all sit around and complain about how bad it is. That's never going to change. So in this analogy and working on our Wizard of Oz theme, some of you came in and maybe you're thinking, you know, CareOregon's a witch. My daughter just read that book in kindergarten and I kind of paid attention. I know there's a couple of witches that are good witches. I hope that you look at CareOregon as one of the good witches. I think it's the North or the South. One of them was already dead, so hopefully it was the alive one. And then there's the wicked witches. And so I would hope that you leave this presentation thinking that pharma pricing is one of those wicked witches. I'm hoping this presentation is a house that has swirled around and landed on one of the wicked witches. Now I'm asking all of you to think about throwing some water at that next witch. So the next time you're frustrated that there was a denial from an insurance plan over an expensive medication, share just a little bit of that love and that frustration the next time that drug rep comes in, or let your legislator know that you are interested. You want to see them take action. I know that maybe this is me standing here, clicking my ruby red slippers, is that right? Very hard, trying to make something happen. Maybe I'm being a little idealistic, but I think the PCSK9s prove to us that with some pushback, with some feedback, and if we stay on it, we can make meaningful change. But sitting around and continuing that everyone talks about how bad drug pricing is, but not throwing any of that water is not going to make any bit of difference. So with that, I thank everybody for coming today, listening to my different perspectives, hopefully not throwing water at me, and that you will stick around for our question and answer session. Thanks so much.